Good evening. Welcome to the Bridge Builders Community Health Forum. My name is Wes Shows. I'm one of the two co-producers of this series. And as usual, we have the other half of this team, Professor Cynthia Davis, on the line, who will also be serving as the moderator. We are delighted you are able to join us for a discussion of this very, very important subject in conjunction with Prostate Cancer Awareness Month, which is September. Typically, the Bridge Builders president, James Breedlove, usually kicks this off by acknowledging the many community-based organizations that affiliate with us. And they're all listed on the bottom of the brochure if you didn't see it. But Jim is away and sitting in for him. So without further ado, I'd like to bring on my partner in this effort, Professor Cynthia Davis of Drew University. I call her Cynthia, and feel free to do so also. Cynthia will pick up from here. She will tell you what we're going to do today, what you're going to get out of this, how you're going to get it, and what you need to do at the end to make it even more effective for both us and you. So again, welcome. We hope you have a great time, and good evening again, Cynthia.
Thank you, Wes. Good evening, everyone. My name is Cynthia Davis, and I'm an assistant professor in the College of Medicine and the College of Science and Health at Charles Drew University of Medicine and Science. I want to welcome you to tonight's webinar on addressing prostate cancer health disparities among African American men. This webinar is part of a quarterly series of health education and disease prevention webinars brought to you by the Bridge Builders Foundation, the Bridge Builders Foundation's Community Health Disparity Coalition, and is coordinated by myself and Mr. Wesley Shows. The aim of tonight's webinar is fourfold. Number one, to provide an overview of the impact that prostate cancer is having among African American men. Number two, to determine how African American men can be better advocates for their health in relation to early detection and primary prevention of prostate cancer. Number three, to present information about local and national public policy and advocacy initiatives that are working to heighten awareness about prostate cancer's impact among African American men, as well as the need for enhanced education on the importance of participating in prostate cancer clinical trials. And lastly, we want to discuss how our community and healthcare providers can work together to reduce the impact of prostate cancer in the African American community. Our guest speaker tonight is attorney Merle Gray Niesenberg. Merle is an attorney working in healthcare and is president of 3 nonprofits in healthcare, 2 national and 1 state. And she does this on a volunteer basis. The first is the National Alliance of State Prostate Cancer Coalitions. The second is the California Prostate Cancer Coalition. And the third is the Clifton F. Mountain Foundation for Education and Research in Lung Cancer. Merle is a member of 2 National Cancer Institute SPOREs, 1 in prostate cancer at UCLA and 1 in lung cancer at the MD Anderson Cancer Center. She is on the UCLA SPORE Executive Committee. Merle is also the advocate for the Canary Foundation PASS trial at Stanford University and is part of a PCORI grant with UCLA dealing with decision aids in prostate cancer. Through Informed Health Consulting, she and her partner help recruit, link patients to clinical trials, and she also creates patient ambassador programs. Merle has been actively involved for almost 10 years as a national patient advocate for the Early Detection Research Network of the National Cancer Institute. handling 3 of the 4 collaborative groups, including genital urinary cancers, GYN cancers, and lung cancer. In her law practice, she has represented many cancer patients and has advocated for them and their families. Merle is extremely interested in the early detection of cancers when they are still curable and is dedicated to improving the lives of patients, including those as yet undiagnosed. Please hold your question during Attorney Nisenberg's presentation and place them in the chat box. At the end of her presentation, I will go to the chat box to have her answer as many questions as possible. Additionally, we have a webinar evaluation form we would like for all of you to complete before you log out of the webinar. And lastly, Attorney Nisenberg's first name spelled correctly is Merel. It was inadvertently spelled incorrectly on the promotional flyer. Without further ado, Attorney Nisenberg.
Thank you so much. I'm just waiting for the slides to come up. Okay, great. So welcome everybody. Thank you for joining us this evening. I've known Wes Scholes for probably 15 or even longer years, although I'm only 28, so I'm not quite sure how that computes. But he's been with us at the California Prostate Cancer Coalition from the very beginning. And we consider him the most valuable, one of the most valuable board members, and we love to work with him. So I was only too happy to accept his invitation to speak tonight. So prostate cancer, it's, you know, sort of a hot button. It's gone back and forth with whether men should be screened and how to treat them. And right now I'm going to tell you about our national organization, which is the National Alliance of State Prostate Cancer Coalitions. And we also call it the Alliance. We are one of the most important national organizations. We represent 46 states worth of prostate cancer organizations. So we form a large critical mass. And whatever we educate our people on, we ask them to share it with the rest of the people in their state, really take all the information from the top of the state all the way down to the local level. So it's even a larger critical mass. We also help set up the state prostate cancer coalitions, and we help mentor them. So if they need help or they need some recharging or ideas on how to run themselves or fundraising, we help with that. Each state prostate cancer coalition, some are foundations, some are associations, but each one is completely independent and it self-manages. So even if the national organization, say, creates its own screening guidelines like we did back in 2005, each state is free to accept or not accept those. So we don't have actual members, we have participating states. And once a year, one of the things that we do that's unique to us, we bring attendees from all over the country, from many, many states, to our annual meeting. This one will be our 18th, and it will take place October 6th to 8th. Wes was a guest last year. And it's an entire weekend of sharing of best practices, networking, education, panels, presentations, and it's just an all-around incredible weekend. And we want people to take that information back with them, whether it's written or what they've learned, and share it with their own constituencies. So it's really, really exciting. We have a top-notch faculty. If you go to our website, which is listed at the top there, naspcc.org, you will see information about the upcoming 18th annual meeting, including the agenda. Our faculty is from the best medical centers in the country, including Memorial Sloan Kettering and Cornell and Mass General, Harvard, Dana-Farber, Johns Hopkins, Duke, City of Hope. We've got a great, great faculty. So it's a great opportunity, and we welcome guests to come, but that's one of the unique things that we do as an organization. Next slide. So another thing that we do that makes this completely unique is that we publish the bi-monthly Prostatepedia magazine. And this is a magazine that's comprised primarily of interviews with the leading lights, the best faculty people in the country, depending on the topic. We publish it in what's called flipping book format, and it's on our website, and it's also sent to everybody on our subscription list. And you just click on the arrow and the pages turn. You hear them actually turning. It then gets archived on our website, so it's available as a continuing resource. Not only do the Prostatepedia magazine in that flipping book format, but every single Friday at 8 a.m. Pacific, we send out the weekly Prostatepedia Digest. I personally curate the articles for this. They are sent out, excuse me, the top portion are links back to the most recent of the Prostatepedia magazine issues. The middle portion are 28 links to different abstracts, news releases, press releases, etc. The most current information on prostate cancer. And then the bottom portion are reminders such as upcoming webinars or our annual meeting or interviews that have taken place. I got to interview Cal Ripken Jr., for example. We were able to interview Grant Hill about prostate cancer and his experience. So this goes out every single Friday. And we have over 20,000 subscribers, primarily in the US, but we also have Australia, New Zealand, lots of Western Europe, and I think some Japan. And the subscriptions are free. So you need to sign up for it, and it will come as an email. Both of them will. We use something that sends it out, and it goes out every single, as I say, every single Friday, and then the bi-monthly magazines also come out that way. So it's a really unique opportunity to help educate people and physicians, because I think that both sides need to be educated. And again, it makes us completely unique. We were offered to take over Prostatepedia magazine in June of 20, smack in the middle of the pandemic. At the time, there were 11,000 subscribers. Now there are over 20,000. So we're really proud of that. Next slide, please. Next slide. Okay. So what we feel is the most important thing that we can do for patients and families and as yet undiagnosed men for prostate cancer is create awareness as well as education. So you have to be aware of what prostate cancer is. You have to be aware for men that they have a prostate. When the task force USPSTF in 2013 told men they did not need to be screened for prostate cancer, it was really bad. After that, physicians stopped mentioning prostate to patients, didn't offer them testing, didn't offer a discussion. And so at that point, we know that the better informed both the patient and the physician, the better informed discussions are going to take place and better shared decision making, because no one should be dictating your health care to you. It should be a joint decision, knowing what all the options are and being informed enough to know what those options mean. So next slide, please. So the benefits of what we call shared decision making: greater patient satisfaction. If you feel like you've helped make the decision, you're not going to be resentful or think it was foisted on you. Better compliance. You're more willing to go along with whatever treatment options or active surveillance, which is no treatment in the meantime. You have less decision regret. If you've made a choice and you didn't like it and somebody kind of cornered you into accepting it, you don't have that problem. You have better outcomes, greater feelings of empowerment, which that makes sense, right? And better emotional well-being, because you are participating in your decision-making and in your healthcare. So that should be a discussion for you and your physician. Next slide, please. Another example of how to educate patients and physicians, because we believe that both the physicians and the patients, not just the patients, need better education. In my law practice, I'm a malpractice attorney, and I see firsthand when physicians are not educated sufficiently on the topic. So I know distinctly that there is a need to educate both. And some physicians are great, fabulous, but many doctors, if they're a urologist, they're handling other conditions besides prostates. If they're an oncologist, a cancer doctor, they're taking care of different kinds of cancer. So in order to make sure everybody's up to date on everything, we want to educate both. So next slide, please. This is an example, and I don't expect you to read this, don't worry. that is what that looks like on our website. That's the front and back of an 8.5 by 11, a normal sheet of paper, regular like a note paper. And what we did was when the USTSPF, the task force, said, don't get screened, the California Prostate Cancer Coalition said, wait a second, that's not right. So we created what we call laminates. And these, don't let the name confuse you. They are simply 8.5 by 11 laminated cardboard. So they are durable. They're shiny and hard. You're not going to toss them away. You're not going to drop them and don't know where they went. They're two-sided, and one side is for patients, and literally the flip side is for physicians. On the patient side, it's 10 questions to ask your doctor, and it's got the answers. And obviously it's a general because you can't get everything on one piece of paper. On the flip side, for the physicians, it's the same 10 questions, but the answers are scientific. They are references to clinical trials or to something in the literature. So we want both sides there together, literally flip side. The patients read one, and we ask them to read the physician side as well. We ask the physicians to read the patient side as well. So each of them knows going into their clinic visit, you know, to have an informed discussion, you have to know what the other side knows. So they're great tools for that. The one that's on the screen now is informed decision-making. And as I say, the California Prostate Cancer Coalition developed this in response to what we thought were very foolish guidelines saying don't get screened. The interesting thing, you see a yellow box on there on the patient, on the physician side. And that came about because we did a pilot project to see, did the language make sense to patients on the patient side? What do the physicians think? Would they read the patient side and their own side? Would it change practice? And many physicians said, we love this, we're going to keep them in our clinic. But 4 doctors came to me and said, we don't think we're allowed to have an informed discussion. So at that point, I went to the actual guidelines, and everybody stopped at the topic, at the title that said, D, don't get screened. But nobody really read through the whole thing. And in the middle of even that D recommendation was a sentence that said, if a patient wanted to have an informed discussion about prostate cancer, the physician must, so it's mandatory, they had to have that discussion with the patient. And it was then up to the patient whether they wanted to get tested or not. Nobody knew that was in there. So we put that yellow box up there on the physician side to let them know that they were allowed. And in fact, it was really a good thing to have informed discussions. So this was the first one. It's been updated, came out in 2013, 14. We updated it in 2017, and just this past May, it's been updated again. It's on the National Alliance website. It's also on the California Prostate Cancer Coalition website. We actually have them produced 1,000, 2,000, 3,000 at a time. They're available for you to use at any health fair, any gathering that you have where you want, even for physicians, they're available. You just let us know and we'll get them to you. Next slide, please. So we call them the laminates, not to be fancy, but because they're laminated cardboard. And by that, we mean they're durable. As I say, you can't fold them up, you can't scrunch them. They actually stay. And what our goal is eventually is to have a ring binder in the left top corner. And for all the topics that we have laminates for, patients will be able to have all of that with them when they go to their doctor's visits so they can have better discussions. So again, it's 10 questions and answers on the patient side, the more scientific answers and references on the physician side. And the best thing, we do double distribution. So we distribute these to patients, to community groups where people aren't yet diagnosed, but we also distribute them to doctors and to clinics. We go to medical meetings, we give these out. So again, that's the benefit. There's nothing really that's two-sided and double directed the way these laminates are. So they are unique. Next slide, please. So other benefits, they're durable, they're easy to store, easy to carry to your doctor's office, and the physicians can also keep them handy in their offices so that you guys can have a discussion and you can pull it out and they should be able to pull theirs out and each party can read both sides. We currently have 6 laminates completed. They are on the website for the National Alliance. So we have the informed decision-making that I just told you about. We have one on the role of PSA throughout the prostate cancer journey. It's an important diagnostic biomarker, a blood test that's important not just for the initial diagnosis or to get you to be seen to see if you have prostate cancer, but it's a good way to monitor treatment throughout. So that's a second laminate. Again, patient side, physician side. The third one is non-metastatic castrate-resistant prostate cancer. This is an advanced prostate cancer. There's still lots of treatment decisions to be made, different approaches. There's also one on metastatic hormone-sensitive prostate cancer. So the hormones are still working for patients. Again, a lot of issues that come up, a lot of questions, a lot of new treatments, new studies, new clinical trials. We have one on imaging, and it's not the standard imaging, although that's included, but it includes the new molecular imaging. You may have heard people talk about something called PSMA. It stands for prostate-specific membrane antigen. It's big words. It just means something that's found primarily in prostate cancer cells. And this spectacular type of imaging can see cancer where conventional imaging sometimes cannot. So it allows you to know what your stage of disease is, whether you have more disease than you thought or the doctor thought, and whether you don't, which is great. And now they're using it for what is called theranostics, that's another topic for another day, but it's using PSMA for treatment along with another drug. And I can answer questions about that later, but so that's 5. And then 6, we have one on immuno-oncology. So immunotherapy has been very successful in certain cancers, such as melanoma and sometimes lung cancer. It hasn't really worked that well yet in prostate, except for a few exceptions. And when they do your blood test and they do genetic testing to see if you have certain mutations, for example, BRCA mutations, you may be able to get a different kind of treatment that's an immunotherapy. It's a PARP inhibitor, it's called. It's only really effective for certain people with certain mutations or certain conditions of their tumor. So that's always good to know, but that's called immuno-oncology or immunotherapy. So we've done 6 of those double-sided laminates. They're all on our website, available. You can go on there, you can download them, you can have them printed back to back, you can have them laminated, made shiny and permanent. We can send you like 100 at a time for any kind of a public health fair, for example. We have 3 more ready to be put together. One is on testing, which is a huge topic, as you can imagine, because it's not just PSA, it's a lot of other things. And we have one on pain management in prostate cancer for advanced disease. And then we have one on bone health, because that's a really important issue. So these laminates, again, are unique to the National Alliance. No one else has anything like it. And we just are really excited that we can help educate patients, their families, and the physicians. Next slide, please. This is an example of one of the other ones. So this was the non-metastatic, they call it CRPC. It's castrate resistant, but you don't respond to hormones anymore. And if you can see, there's 10 questions in blue with answers in black. And the physician side is with the yellow box, and that's got the more scientific references. At the bottom, you'll see knowledge is power. And that's one of our mottos, because if you know something and you can deal with it better because you can make an informed decision and you can help and participate in better shared decision making. Next slide, please. And now we come to the California Prostate Cancer Coalition, which is important since we're pretty much all in California, and we may have a few other people. We formed this in 1997, and I've been president since. Nobody else will take it over from me. But we work with CDOC, which is the California Comprehensive Cancer Control Plan that is run by the CDC, the Centers for Disease Control in Atlanta. Every state has a comprehensive cancer control plan. They don't all cover prostate. And when they do, they don't all have a plan for prostate. They just say that we cover it, but they don't really do anything with it. And I have to tell you that when we first did the laminate in 2014 and took it to CDOC, at that point, they had a comprehensive plan, a 5-year plan that said they wanted to increase the number of men who had an informed discussion with their physician. And this is incredible to me They didn't have any plan to get that done. They just put it in the plan as something that sounded like a noble goal. And when we brought our laminate to them, they said, thank goodness you found a way to actually help us effectuate this plan, because we had no idea how to do it. And then we went to CDC in Atlanta and asked if they would mind if we put the laminate on the website for Public Health Department for California. So we do help CDOC, as they're called, the California Dialogue on Cancer. We help them with their 5-year plans for prostate. They have sort of backed off. CDOC it follows this. It's very complicated, but the task force that I told you about, the CDC kind of follows the task force, even though the task force isn't really a government entity. And then the comprehensive cancer control plans in each state are from CDC. So you see a reticence to really put prostate cancer up there. With the California Division of American Cancer Society that I used to co-chair their prostate cancer task force, when I started, they were really big on prostate cancer. And then at one point or another, they put it on the back burner, and then they took it off the stove completely, as I say. And now, just now in the last month, because statistics have shown that incidence of advanced disease and mortality is increasing, prostate cancer, they have now instituted a whole new program. And part of what they're developing is a big permanent roundtable. In fact, we're going to meet again at the end of this month. And they are totally interested in screening and educating men. It's like a completely different organization because they have new leadership. So anyway, the California Prostate Cancer Coalition, I'm very proud of this. Wes has been on our board from the beginning. We try to bring the entire state together. And the reason we formed is because we were told it can't happen. The state's too big. So we were like, okay, watch us. And so we do everything by conference call, by Zoom. We cover the top of the state, Eureka at the very top of the state near the border with Oregon, all the way down to San Diego and point south before you get to Mexico. And we network all the support groups in the state. So we have a directory on our website. And if you need to find out if you're diagnosed and you want to find a local support group, you go on the website where you contact us. We also do support group leaders training. So we try to do a lot of things. And now since 2019, we have been having a giant annual prostate cancer, patients conference on prostate cancer. It's a CPCC effort with UCSF, the University of California at San Francisco, which, as you may or may not know, has one of the greatest urology faculty in the country. So we've been doing that. The first one we did in June of 2019. We had over 400 people standing room only. And our fourth one, which we'd like to tell you about, is coming March 9th of this coming year. And it will be at UCSF in San Francisco. It'll also have a Zoom element, so you can actually go on and listen remotely. But it's a day-long, incredible program. It was videotaped. They've all been videotaped, but from the first one on, the first three, this number 2 and 3 were remote because of COVID. And they didn't get the same, I don't think, the same viewership as in person. But right now, that video is on the YouTube station for the University of California. And as of about a year ago, it had already been viewed over 250,000 times. So it's a great event. So we're really proud of working with them. Next slide, please. Oh, I guess I've come to the end. So we're really lucky tonight. And I know you're going to have a lot of questions. And I tried to talk slowly. Sorry if I went too fast. We're very lucky tonight because not only are we a national and a state organization, but there's an international organization here. Movember, you probably heard of it. And we have Ami Shah, who is the Global Implementation Director. And she's going to show a few slides and tell you about Movember. And then you'll be able to ask questions of both her and me. So Ami, let me turn it over to you.
Great. Thank you, Meryl. And thank you all for being here tonight. So yeah, Wes has graciously invited us to also give us an opportunity to share a bit about our work. Some of you may have heard of Movember. It's this movement where men grow out their mustaches in November. I'm not sure, have you all heard about that? Anyone? Yeah. Okay, so Movember is changing the face of men's health. We're a men's health organization. You can move to the next slide. We have a Santa Monica office, but our headquarters globally is in Australia. We're in several markets and several countries around the world. We've been around since 2003. We started as a small group of guys that were interested in making a difference and thought that growing a mustache might be kind of fun. So they raised a lot of money over the years. And in the last 20 years, we have raised over $980 million US dollars. And there's been over 1,250 projects in various countries around the world. Our focus areas are in prostate cancer, testicular cancer, and in mental health. I would say we started in working on men's cancer because they were sort of paralleling their work to the breast cancer movement, just as a lot of men like to emulate women, they don't realize that the breast cancer movement has been really powerful and a lot of advocacy. And so I think the prostate cancer movement is now starting here with Movember is what the intention is. You can go to the next slide. So as I mentioned, our 3 cause areas are these, and basically that testicular cancer, we know that #1 cancer among young men, mental health, we see that every minute. And 1 man dies globally by suicide, and then prostate cancer. I'm going to hone in on prostate cancer. We know that 1 in 8 men get it. And as Meryl said, there's a lot of work being done around education. And so we just wanted to share some highlights of where we're going and where we've been. Go to the next slide. So in the past, we have invested the last 20 years, there's been incredible investments in the biomedical side of our work, mostly in the science, bench science. We've worked with researchers and partnered with communities to help guide the research. And in so doing, a lot of advances, as she said, with PSMA, that was FDA approved as a result of some of the clinical trials that Movember funded. So over the years, I would say that our investments in the science has been incredibly powerful and has resulted actually in really effective treatments that are now available for most men that have prostate cancer at various stages. What we haven't figured out yet now is how do we now bring this to fruition? How do we implement this in communities? How do we translate this into our communities so that all men have access to these advances in technology, really, for prostate cancer? So we have just changed our strategy recently. And so instead of just funding different cause areas like, testicular cancer or mental health and prostate cancer specifically, we're taking a whole man approach. And this is now our new strategy that's coming out in 2023. We just launched it. And we have 5 major goals. I won't go through all of them, but they're pieces of the health literacy, lifting the profile of men's health, as Meryl talked a lot about the literacy piece and communication between men and the provider, promoting gender responsive healthcare for men so that it's really culturally appropriate for men and that there's different ways in which you might want to approach different men. Young men's mental health. And then as I wanted to really talk to you more about the prostate cancer, since that's the audience here, we're investing quite a bit in the prostate cancer, ending mortality, but also making sure that men that live with prostate cancer are living and have a good quality of life. So the next slide. So our major areas, as I mentioned, we've led the way in prostate cancer research. And we now have a new strategy, and we're really focused in on personalized care. So we know that some men might need different information because not everyone's getting the same information. There's issues around equity, whether there's access to the same services that are available or the same advances in technology. Does everyone have the same access? And quality of life. So in survivorship, we've got some registries that we've funded for over the years, and those registries are telling us about patient-reported outcomes. So men are actually, after having treatment, they're able to report back on what are their symptoms, what are they feeling, and that can then be put back into clinical quality, right? So the idea is this cycle of bringing information back. Our major initiatives we're really excited about. There's a new National Health Equity Grant that's actually going to be announced this month. There's a study going on around active surveillance. How do we best encourage men to not have to, like, why do 80% of the men, like, they actually jump into treatment because of fear of staying in active surveillance? And then preventing disease progression, as Meryl said, that we're seeing advanced disease increasing. Why is that? And how do we try to prevent that from happening? We've created some new guidelines on sexual health and wellness, again, around men living with prostate cancer, understanding where and how physicians can better serve men's mental health and sexual health. And then optimizing the use of patient-reported outcomes, as I just mentioned earlier, that men are able to report back on what are their symptoms, how can we have better communication between the providers and men so that they can report back. So yes, and given the stigma associated with it, it's really important to have these avenues and mechanisms. So if you'd like to learn more, we welcome you to join Movember. We have a community. People are welcome to sign up. Some people like to fundraise and others just join the community and are part of the movement. So you can go to that website. It's at Movember.com. It automatically populates to the US. So we just wanted to share a bit about that. I think that might be my last slide. Is that it? Thank you. Yeah. So again, we're lifting the faces of all men, and we like to hear from different people with all different backgrounds. So we welcome you to join, and thank you again for giving us the opportunity to share a bit about Movember.
Can I just add something, Wes, that I forgot to mention? So
Right.
Prostatepedia is actually coming out with a special issue for the late fall, and it's entitled Black Men and Prostate Cancer. Movember will be one of the sponsors of the issue, but it will be amazing. We have incredible faculty being interviewed, and we've never done anything like that before, and we're really excited. So that will go out to over 20,000 people. And Wes, I will send you the link how to subscribe to Prostatepedia, which is, I say, it's free subscription. And from then on, you will get all the magazines, and you'll get, and MailChimp sends it out, you'll get an email, and every Friday, you'll also get the digest.
Yeah, well, thank you, Meryl. And Bill, as a follow-up for us, we want to make sure that these data are included in our regular network, both for CPCC as well as Movember. And for those of you who are either member of Bridge Builders or member of the Federal Chapter, I've started dialogue with Ami and her colleagues as to how we can create for Movember what we used to do on an annual basis for the runs for breast cancer. Our goal will be to kick that off for the November 2024 session. And also because of this, guys on the staff, I'm going to need your help, and along with Cynthia, to figure out how do we distribute these data that we have learned about tonight on a routine and broader basis. And the whole intent of this session and having my two colleagues here is to hopefully spark some interest on your part to A, learn more, and figure out B, what you can. So, thank you. All right, Cynthia, looks like you're back in the left seat in the cockpit, huh?
Well, let's see what question, can you hear me?
Yes.
Let's see what questions are in the chat. One of them is, let's see, given the stigma associated with any type of cancer, are there any model programs which have proven to be effective in increasing prostate cancer awareness, as well as linking African American men into prostate cancer clinical trials?
Meryl, you want to try that one, then I'll add to it if necessary.
Yeah. Well, I think, we're trying to get more inclusion into clinical trials. First of all, it's hard to get anybody into a clinical trial. There's only about generally like a 3 to 4% of possible patients joining clinical trials for a number of reasons. So one of the things we do is also help get people into clinical trials, we actually try to match the patient's condition with the clinical trial. So it's not just a website, here's a bunch of trials, people go, go to clinicaltrials.gov, that doesn't really do anything. So we're trying to do that. And we're trying to be cognizant of the different issues. There's access issues. But as I say, we're excited about this issue of Prostatepedia magazine coming out because I think it's going to cover a lot of that. And the people that are interviewed have been interviewed already for it. I think it's going to be an outstanding publication. It'll probably cover some of those issues that I'm using the term issue as magazine issue, but also the main issues.
Thank you.
I'd like to add to that, Ami?
I mean, I guess just historically, I know there's been a lot of work being done around the barbershops in the Northeast area or the Southeast area, like Atlanta and North Carolina, and they've been very effective, especially with education, using the barbershop model.
Yeah, that's one of many. And as I reflect over the last 15 years, I've sat through probably hundreds of millions of dollars of grant applications, all focusing on the question, how do we get people to understand their responsibility and what they need to do? It's an ongoing question. I would say that what's been accomplished is incremental, but very, very slow.
The next question, thank you, Wes, is sort of linked to the statement that's on the front of the promotional flyer, where the American Cancer Society, from their facts and figures statistics, they state that in 2023, there'll be an estimated 288,300 new cases of prostate cancer diagnosed in the United States, with a little over 34,000 deaths. So I wanted to know how many cases of prostate cancer are reported annually in the state of California, where we live, and of those cases, how many are diagnosed among African American men? That's my first question. And the second one is, why do African American men experience such high rates of prostate cancer?
Merle, I don't have the stats handy. The breakdown of that number by ethnicity, so I would only be guessing on that. I can't.
Well, I was going to say that our board member Bill Doss prepares for September every month, which is Prostate Cancer Awareness Month, a proclamation that he wants everybody to take to their mayors of their cities and to their county boards of supervisors. And he attaches all the American Cancer Society statistics for each state. So that's probably on our website for CPCC right now.
Okay.
But traditionally, Black patients with prostate cancer double the incidence of prostate cancer, and I think it's 1.5 times the mortality. And so, they're looking at it from many different aspects, socioeconomic, access, insurance. And then you have a whole nother, I don't really know how to term it, but Otis Brawley, who used to be with American Cancer Society as a chief medical officer, he was on a call with me and he was saying, well, we can't say African-American men because a lot of the Black patients are actually European ancestry. And so he's saying that to say African-American men, that's like a social a construct. It's not really real. And we need to further delineate who's coming from where to look at ancestry. So that's a whole new topic that is being discussed.
And another complicating factor is a lot of studies are being done both here in America as well as in Europe, and particularly in Africa. And one of the difficulties that researchers are having is differentiating amongst the various country groups, maybe. What is it African American? And how do you distinguish between the the Blacks from Africa versus Blacks from the Caribbean? There are apparently some differences, and even on the African continent, some of the studies are showing major differences amongst the people there, depending upon the part of Africa. We'll probably be talking about these questions 20 years from now, because when I was first introduced to this whole system 25 years ago, those were some of the key questions that were being raised.
There are a couple other questions. How would we get a copy or a subscription to Prostate PD? And can the slide decks be shared?
Well, I'm going to send Wes the link to subscribe to Prostatepedia. I'll send it either tonight or tomorrow, Wes, okay? And then if you just distribute that. And I have no problem with sharing our slides.
Okay, Bill, are you still there? Bill?
Yes, I'm here. I'm here.
That's key follow-up. So make sure I/we do those two things.
Absolutely. Absolutely.
Thank you so much for that.
I have another question. When should African American men, be screened? How early should they be screening for prostate cancer? And then how early should we be educating youth, young males about the need to screen for prostate cancer?
Okay, well, the California Prostate Cancer Coalition and the National Alliance, our guidelines are 40 for first PSA or 35 if you're high risk. And that means African American or family history, like close family relatives with prostate cancer. Now we know genetic testing, if there's BRCA mutations in the family, even if women have had breast cancer from BRCA, the men have a higher risk of prostate cancer. So it really needs, and now, by the way, they've also included people with Agent Orange exposure in Vietnam, flight engineers, fighter jet pilots, all people who are exposed to excessive radiation over the course of several years. They all should be screened earlier, and it's the first PSA. And you can, depending on what it is, you can wait a certain length of time before the next one. And as far as youth, I mean, we believe it's never too soon to start letting youth know it's something they should be looking for. And a lot of times it's youth that get their fathers to go get screened. So we think that's really important. And it also encourages a healthy lifestyle when they're in high school and onward. So they're not just looking at this, with a high fat diet when they're 45 or 50 or 55.
If I can just add to that, Cynthia, you are well aware of the programs we bridge builders have. And Bill, how big is our population now? 500-600 kids?
Yes, about 600, about 600 or 700 kids.
One of the outcomes I thought from this is I'll be talking to Jim about how we can, Cynthia, incorporate exactly what the question you raised into our educational programs. And of course, as you know, you'll be a major instrument in helping us figure out exactly A, what data to use, and B, how to do it. But yeah, we have our eye on that objective, as is the case with many things. We just got to figure out how to do it in an effective way.
Well, I'd just like to say before I ask this next question, Merle, the information that you've provided is just phenomenal, because these are all resources that at least I know I was not aware of. I don't know how many other people on the call might not have also been aware of. And these resources are free, So I just really want to thank you for coming in, sharing this information with us, because now we have no excuse. We can't say we didn't know now, based upon the information that was provided tonight.
Right.
The next question is, what do studies have to say about various vitamin supplements that claim prostate health and support?
It's always controversial. At one point, everyone said you should be taking selenium, and then that was shown not to necessarily decrease the incidence of prostate cancer. I think generally, I mean, the nutrition information that is presented at all these meetings doesn't really change very much. It's really like a healthy diet, low fat, try to curb some dairy, but don't eat a lot of meat. And then also exercise, and the usual health diet is what they're talking about. And no matter when, the UCSF program we've done now, this will be the fourth one, but the people they have discussing nutrition, it never changes. I mean, I kid around because I'm the steering committee. I'm like, we just say ditto, because we don't even need to take that time and give it to the same talk. That's been pretty much proven. So we really need to just effectuate it to really put it into practice.
Thank you. I don't see any other questions in the chat box. Does anyone else have any questions? This is an opportunity. You don't want to let it slip by.
Okay, if not, there's always the option of sending an email to Bridge Builders with any subsequent questions that come to mind. That's one. Number two, if you have any suggestions on what we are doing relative to this question and how we are doing it, we are open to your suggestions. There again, send an email to Bridge Builders, and Bill or the staff will get it to James, Cynthia, or myself, and we will follow up. Our only request is be as specific as you can. Okay?
Additionally, before we log off, and it is almost 7, we do have a webinar evaluation form that's in the chat that we would like for you to go to before you log off. I see I have another question. I'm going to go to that real quick. But please, before you log off, go into the chat to that webinar evaluation form. Let's see. So someone put in the Bridge Builders Foundation email address in the chat. bridgebuilders.bbf@gmail.com.
Now, Bill, did you do that?
Yes, I did. That's the email address that they would that they would use.
Yes.
Well, if there are no further questions, my sincere.
Here's another. They said another question. Let me see. I'm looking for it.
I just put the link in for the survey.
Oh, you added it in the link again?
Yes.
Okay, thank you.
Posted it a couple of times to make certain.
Thank you
folks
for
had a chance
inviting
to
us,
it.
Wes. Thank
Oh.
you. And Cynthia, thank you for inviting me and myself.
Yeah.
You're
well,
welcome.
Yeah. Well, it is our pleasure, and we cannot offer too big a thank you also for the time that you took to do this. And for sure, you'll hear more from CPCC. As Merle indicated, she and I have been bumping around for at least 20 years. And if I can just point out, if I can make a reference to Movember. Movember is changing their course, if you will. Is that a fair statement, Ami? I've been on their advisory committees for about 7 or 8 years, and Ami's position is a new position. If I understand it, she is redefining how Movember will approach the U.S. population. Okay? And just a couple of days ago, she and I had a conversation, or Cynthia and I don't remember, with another Movember individual that has international scope of responsibilities. And they're moving in a direction that would involve more direct communication with organizations like Bridge Builders. Okay? So we're hopeful that in the next 6 months or so, bridge builders will be able to apply for one of the new community-based grants that they will be issuing. Not a grant for research test tube work like they traditionally. This is a major, major change in an environment, and CPCC will probably also be looking at those RFPs. So I think the bottom line is there's more like this to come.
Great, thanks, Wes. I also just put, if you are interested in receiving a notice about the grant that's coming out this month, you can sign up for an email, or you can feel free to contact me. My contact information's there. You can email me directly or through Wes, and I'm happy to talk to you more about it. I think examining the local level disparities, the question of why in our community, I think would be really relevant, especially because that why can lead to then addressing it. What can we do to make things better?
Yeah, thank you. And as a general rule, the affiliates that we kind of hang out with, all listed on the bottom of the slide, they're like women's groups or sororities or other fraternities. They typically have not had the capacity to respond to RFPs like this. And until very recently, even bridge builders, but it's a new world for us now. So we will be leading in that effort. And for those of you who have an interest in continuing to talk about this, just contact us at Bridge Builders, and either Jim or I will contact you to let you know if and how you might get on this train. Well,
Thank you.
Meryl and Ami, and thank you from the bottom of my heart. Meryl, have a great trip to DC at 6.
It's Boston.
Boston, 6:30 tomorrow morning. And thank you for doing this tonight. And for all of you who helped make this happen, and you know who you are, thank you so much. And of course, Cynthia, you're always here, and thank you.
Thank you.
Thank you.
All right.
Bye-bye.
Have a good evening.
Bye.
Bye-bye.